welcome to yet another special episode of HitCast, the official podcast of the Croatian Society of Emergency Medicine. We are here in beautiful sunny Opatija at the Southeastern European Emergency and Disaster Medicine Conference and also the Croatian Society of Emergency Medicine's National Conference. And we are so happy, so glad, so honored to host as our guest the president of EUSEM, Dr. Robert Leach. Thank you so much for coming. So glad to have you on, and we hope you enjoy the show.
Thank you very much. Thank you.
So, first of all, a very introductory question. How do you like the conference? How do you like Opatija?
Well, actually, I wasn't able to visit Opatija very much. I was able to take a tour yesterday with some of my colleagues, and it's a city I have to admit I didn't know, and so I find it's actually quite pretty. And the seacoast is beautiful. And well, when I arrived, I brought some Belgian weather with me. And so it was quite rainy the first day, but since it's just beautiful sunny weather. And the Congress, because we have to talk about the Congress.
Yeah, absolutely.
Exactly. No, just not talking about tourism for Opatija. The Congress is good. It's really good. The Croatian society, along with the SEE countries, were able to get this year an excellent group of international speakers, as much for the pre-courses as for the courses and the speeches themselves. And fascinating, they had an excellent panel of speakers. So I was very impressed. I was not able to attend all the sessions, but the sessions I did attend, there was quite a bit of interaction, and I thought it was really interesting and worth the time. Sometimes people believe that, oh, it's my national conference, so it's not as good and not as interesting. That's wrong. National societies can do an excellent job, and at national society conferences, very often you will have the opportunity to meet with the speakers, where in a big congress such as EUSEM, you may not be able to because there'll be a big crowd around these people, or these people will be moving in and out. But sometimes with the smaller national conference, you're able to really interact with the speakers. So I think it's a real opportunity.
And we're so glad to have you here, and thank you once again for being a guest at our conference and having you here as on the podcast. It's such a great honor. So, on the topic of, let's say, more professional matters, we're talking pain management guidelines today. So, as you all know, or shall know now, EUSEM has released a 2025 update on its pain management guidelines, which is a glorious 130 plus page document on everything pain management related for emergency physicians. And Dr. Leach is one of the authors, so I'm so very glad to have an opportunity to ask him everything I want to know and maybe you wanted to know about the guidelines. So to start off, can you tell me how the 2026, that is 25, edition is different from the previous 2020? What has changed? Has much changed? Has little changed?
Our first edition, we really felt that we needed a basis to address pain in the emergency department. Everyone knows that pain is the chief complaint amongst patients going and addressing to an emergency department. They come in, I have pain in my stomach, I have a headache, I have pain in my knee, pain in my back. This is a major complaint. And what we've realized is that it's very poorly treated. And we, as emergency physicians, should practically be the specialist in pain management, especially in acute pain management. And there was absolutely nothing about how to address this subject. So a group of us got together and we decided we need to do a guideline. And we did the guideline right before COVID. And then of course COVID happened, and a few of us got together saying we really should update it. And now you have to realize that the update in pain management is not going to be like an update in the ERC resuscitation guidelines, because there is not so much advances in technology, there is not so much new medications on the market. But the idea is to keep it up to date, to eliminate medications that are no longer used or that are considered no longer useful, or to add on to medications that are. And also the entire discussion about opioids. Because of course, there are countries with significant problems with opioid use and mainly abuse. And so these are topics that we wanted to address, but we address them, I would say, probably a bit more philosophically than, for instance, we do talk about high evidence, high recommendation and this, but that's not what we were wanting to do. We wanted to simply say our guidelines just have to be updated, retweaked if you want. But when you're talking about medical guidelines, you can't say retweaked, so we say updated.
So let's address these points you mentioned one by one. So you said we should be, and we probably are, I'm sure we are, the specialists for pain management, the almost experts in pain management. What would you say is the current state of pain management across European emergency departments, and what are some of the biggest, let's say, gaps in providing quality pain management care that we yet have to address?
Well, let me stop you first. I think that what we should say is we could be the specialist in pain management. We aren't necessarily. We are not necessarily because we're not always very concerned with the pain. We're much more concerned with realigning the fracture. We're much more concerned with the reanimation, with the different things that are going on within our departments. And sometimes it's very easy to say, you know, this patient could have taken something at home before coming into the emergency department, so they can wait. And so that really reflects a bit on our efficiency as pain therapists. So for me, we have the opportunity to really become specialists in acute pain management. And one can even extend a bit to say maybe we should be specialists in a lot of different types of pain, not exclusively acute medicine. There is a book coming out which I will be prefacing soon enough. This is not a publicity. It's going to be talking about treating all sorts of pain in the emergency department. Of course, they will be using the EUSEM guidelines for acute pain. So I think we have the possibility, but for the moment, we are not doing what we should do. And why is that? Because a lot of patients in the emergency room are not either not assessed, that's still a problem, not reassessed, still a problem, or inefficiently treated because we have sometimes guidelines or habits that are just easy to do. So I think that the idea of the guideline is not to completely change the countryside of pain management. The guideline is to reinforce, and I'll allow myself to say retweak a bit, some of the new things and some of the stuff that's getting a bit sort of old and no longer considered best practice.
That's great to hear. And I love the approach to pain management, and that the first step is actually making people aware that pain is an issue, and like you said, assess, reassess, treat. So what's the position of the current guidelines regarding opioid use?
Well, you know, opioids are very efficient painkillers. And so, whereas abuse or misuse is problematic, in a context, and this goes for all medication, any medication that is abused or any substance that is abused is nefast for the body. So I think that one should not be afraid of opioids, but one must realize that there are situations where if it's not completely put into a frame, that there can be misuse and thus problems. So the guidelines do not at all discourage, they encourage intelligent use of opioids. And I think that that's something we really should keep in mind. Because if one wants to be efficient in pain, one must use efficient medication. And when we are talking about severe pain, and one starts their protocol or their treatment with a weak painkiller, well, you're setting yourself up for failure, therapeutic failure. And so the question is, why not start with the opioids and scale down?
And that makes a lot of sense. So regarding two other methods of pain management, I want to ask you about the guidelines position on first non-pharmacologic, so some kind of basic measures, and others some new measures, let's say, or novel techniques like regional anesthesia or peripheral nerve blocks, which we heard a lot about on the conference.
Well, firstly, of course, I think we've all been in our emergency departments where we see our patients sort of hobbling about from one room to another because they have a sprained ankle or pain in the knee. I see that in my department, and I think, give them a wheelchair. Remember, rest, ice or cold packs, because of course no one uses real ice in emergency departments for hygienic reasons, compression and elevation. These are basic techniques, and it's a reflex. When I hurt my arm, my reflex is to hold my arm. It's to immobilize my arm. So when you have someone with pain, of course you can't immobilize a head when someone comes in with headaches. However, you can try with cold pack. When I was a young doctor, we would sometimes give cold packs. Now people don't do that so often, but that sometimes, depending on the cause of the headache, that sometimes can relieve. So I think we must not forget that a lot of acute pain is physically caused, and so that one should address those aspects, because if you have a broken arm and I pull on your arm, I can give you quite a bit of morphine and you're still going to have a lot of pain. And I can give you so much that you become euphoric, but you probably still have pain if I keep pulling on it. So the idea is really those basic, rice is the foundation of pain. And I believe that if we do not start with that foundation, we will have to increase our doses or increase the medications that we give unnecessarily, in my opinion.
That's right. And what about nerve blocks and regional anesthesia in general? Does the guideline also incorporate in those techniques?
Yes, and you know that is something that here was very important in the pre-courses. And it took a very important role in the pre-courses. They had excellent teachers to show how to do nerve blocks. And I believe that nerve blocks we should be using much more often because it very quickly relieves patients. In my department, we do, depending on the case, sometimes hip blocks pre-hospitally for hip fractures. And it's so reassuring for the patient, for the family, and even for the doctor receiving the patient, for the patient to come in with their fracture and they're not in pain. It's a pleasure, honestly, for everyone, especially the patient. So I believe that nerve blocks and nerve blocking will become more and more part of, I don't want to say basic, but part of the pain management artillery. And I think we will see that the place of nerve blocking will become more and more important.
Thank you for the answer. Now, we went through a lot of aspects.
Excuse me, at least I hope it will. At least I hope it will.
Me too, sharing your hopes cordially. So, we went through a lot of different topics. We went through the philosophical aspects and practical aspects of basic pain management, the non-pharmacological methods, the opioids, now nerve blocks. And in order to, let's say, make a full circle, I would like to ask of you for a few take-home points for everyone listening. So everyone who's listening is probably an emergency physician and is handling and managing pain on an everyday basis. What would be your let's say, most important messages to them while they're doing their job?
Well, I think probably the most important thing is not to ignore the pain of someone else. We have all heard the expression, thank God men don't give birth, because we would have no children because they can't take pain. And so you have this judgment coming in that when someone says, I have an EVA of 7 or of 9, oh, she's hysterical, he can't take pain, and all of this judgment, which is not at all constructive, and it helps no one. Now, so I think the first thing is to understand that if someone comes in with a 8, that 8 could be maybe a little less than a real 8, but because there's anxiety, because there's fear, it becomes an 8. And I don't think that's so bad. I don't think we have to judge. If my patients come in with a 5 or a 10, they still have to be treated. And so I think we have to get away from that judgment. And very often, the judgment is from the very start. Sometimes even the secretary say, yeah, he's sort of exaggerating. And then the nurse already is sort of pre-medicated to, oh, he's exaggerating. So when she asks, it's sort of, what's your pain? And so I think what we have to do is we have to, especially as physicians, but also as nurses, we have to go back and we have to say, on a scale from 1 to 10, where is the pain that you have today? And explain what that means. That's for the people that are cognitively capable of answering, for children and for the elderly that have dementia. We have other scales. They have to, the idea is evaluate, assess, reassess. And when the nurse comes in and says, doctor, in room 3, there's a sprained ankle, he has an EVA of 7, then what you can say is, okay, follow the protocol, or you give what you believe is the most adequate. Okay, you give it. But then you don't forget, is in other words, okay, I'm going to take care of the next patient. No. You must reassess. Is your treatment efficient? So if there is a message, the guidelines are guidelines. They are not, it's not a recipe book. It's to say, within my context, within the medication that we have in our country, in my hospital, what and how should I address acute pain? That's number 1. And number 2, to address it, you have to identify it. We cannot do ultrasound to identify pain. We cannot use our stethoscopes to identify pain. So we really have to interact with the patient. We have to respect that interaction. And even if down deep we feel that they are exaggerating in their pain, that doesn't mean that the patient suffers less than what they describe to us. So assess, reassess, and if you're not satisfied because the number has not decreased as much as you would like to, don't say, oh, they're just exaggerating, I'll just leave. Think of what you can do elsewhere. And review, have you immobilized the wrist that when you gave the painkiller didn't really give the delta that you were looking for?
Thank you very much for the answer. I think it encompasses and perfectly circles out the things we talked about today. Thank you again for being a guest both at the conference and at the podcast. I'm sure everyone is going to learn something for their daily practice in this very, very important topic that we actually deal with every single day. Thank you, Dr. Leach, and enjoy the rest of the conference.
Thank you, and I just want to sign off by saying that the guidelines, it's a group work, it's a group effort, and we will be eventually revising and updating again. So if people are interested in pain medication or pain management, please, you can contact me or any of the authors, because the more people we have, the more contributions we have, the better our guidelines will be.
Thank you.